Your lines have been muted, but there is a chat box. So if you have some questions as we go through this, if you'll write your questions in the chat box, we'll see them and we'll try to give you as many answers as we can at the end. Anything else? Okay, so I think we'll go ahead and get started then. And I wanted to once again say hello and thank you for joining us. This is the last webinar in the series that's being brought to you by SDHIMA and HealthPoint. We hope the information that we've been giving you throughout this series has been helpful to you. Today we're going to address some specific diagnoses that have probably been seen in your practices. Okay, let's get down here. Thank you. Okay, hold on just a second. So getting started here. My name's Linda Parks. I'm your presenter today. I teach health information management at Dakota State University, but I'm here with you today in my capacity as a member of the South Dakota Health Information Management Association. Our objectives today are pretty straightforward. We want to look at coding and documentation requirements for a few of the diagnoses that have been identified as some of the most frequently seen in family practices and internal medicine practices. So, why do we continue to talk about documentation? Because documentation captures the level of risk and severity of the patients you're seeing. It supports proper payment. It assures accurate measures of quality and efficiency. It assures accountability and transparency, provides better business intelligence for your practice, and enhances communication with other providers. With ICD-10-CM now, we are able to communicate the documentation more effectively and more efficiently. Physicians are taught to document these items that you see on the screen. Things like type of condition. For example, is it type 1 or type 2 diabetes? The onset of the condition. When did it start? The etiology or the cause. Was there an infectious agent, a physical agent, or something that's congenital? The anatomic location. Which anatomic structure are we talking about? And then is it proximal, distal, medial, lateral, peripheral, superior, inferior, anterior, posterior, or just where is this? And that refers also to laterality, right or left side. Severity. Is this documented as mild, moderate, or severe? Time perimeter. Sorry about stumbling over the word. Here we're talking about, is this condition intermittent? Is it acute or chronic? Is it postoperative? What are the manifestations, or are there any? Are there any comorbidities or complications? For instance, does this diabetic patient have neuropathy? What about findings and symptoms? Does the patient present with a fever, wheezing? When you do the lab tests, are they hypoglycemic? External causes. Is this work-related? Is it accidental? Were they involved in a motor vehicle accident? And environmental factors now are things that we're being asked to keep track of, and things like, is this patient a smoker? Nothing new here for physicians, because they're already documenting these things. We just need to make sure your documentation continues to be complete so that we can accurately report the conditions. This will help your practice as changes in payment models will leverage these key medical concepts that are now being defined in ICD-10-CM codes. And whoops, I didn't realize we jumped so far forward. Sorry about that. Okay, So what we're going to look at today is some common codes for your practices. To begin with, think about the most frequent diagnoses that you see in your practice. Of course, each practice's list will vary according to specialty, patient population. Just moved again. I don't know why this keeps moving on its own. I'm sorry for you who's watching. Just a minute, see if we can take care of this. I need to go back. Again, yeah, and again. For some reason, the computer thinks we really need to be talking about hypertension today, and we will get to that in just a minute. But first, what I wanted to tell you about what I'm looking at today, the diagnoses that I've picked to talk about the codes and the documentation for, come from a study that was done in 2013 to 2014, and it's published on the CMS website under the title Road to 10. And the list includes these things you see listed here: abdominal pain, otitis media, hypertension, diabetes, COPD, which will include chronic bronchitis and asthma, and acute respiratory infections. I want to spend a little time now to look at a few of the guidelines that apply to the ICD-10 codes for some of these frequently seen diagnoses. There are three main categories of documentation changes in ICD-10. These are changes to definitions in the classification system, differences in terminology and increased specificity, and the examples that fall in these categories. So here we are, finally to hypertension, where the computer wanted us to be. Hypertension is a definition change for ICD-10. In ICD-10, hypertension is defined as essential or primary. The concept of benign or malignant hypertension that we used to see in ICD-9 no longer exists. When documenting hypertension, then, it's important to include the type, is it essential or is it secondary, and document any causal relationship between hypertension and coronary or renal disease. This is essential hypertension as it appears in ICD-10-CM. A diagnosis of elevated blood pressure reading without a diagnosis of hypertension would be assigned to R03.0. I-10 code is never assigned on the basis of a single blood pressure reading documented in the medical record. The physician must specifically document a diagnosis of elevated blood pressure or hypertension. And you'll see that's what this is trying to tell you. Certain heart conditions are assigned to category I-11, hypertensive heart disease, when the causal relationship is stated or implied. So if it says that heart disease due to hypertension or hypertensive heart disease, that's when we use I-11. Hypertensive heart disease includes heart failure, myocarditis, cardiomegaly, cardiovascular disease, and degeneration of the myocardium. Category I-11 is subdivided to indicate whether the heart failure is present or not. However, an additional code from category I-50 is still required to specify the type of heart failure if known. So this is what it's telling you. Use an additional code to identify the type of heart failure. A cause and effect relationship between hypertension and heart disease cannot be assumed. If the diagnostic statement mentions both conditions but does not indicate a causal relationship between them, separate codes are assigned, with the sequencing being dependent on the circumstances of the admission. For example, here we've got a statement of a patient being seen for myocarditis, chronic combined congestive heart failure, and hypertension. Following the guidelines, and that's what I've got in the little box here, when there is no statement, either specific or implied, of a relationship between hypertension and heart disease, separate codes are assigned. ICD-10 does not presume a causal relationship, even though hypertension is a major cause of heart failure. So in this scenario, we would have these three codes. On the other hand, where there is a definitive statement of a relationship between the hypertension and the heart disease, a code from category I11, hypertensive heart disease, is assigned along with the code from the category I50 for heart failure to identify the type of heart failure. So this is what you would see under I11. Again, use that additional code. Let's look at coding hypertension and chronic kidney disease because that's different. When the diagnostic statement includes both hypertension and chronic kidney disease, unlike hypertension and heart disease, ICD-10 does assume that there is a cause and effect relationship, and the code from category I12, hypertensive chronic kidney disease, is assigned. A causal relationship need not be indicated in the diagnostic statement. The appropriate code from category N18 then should be used as a secondary code to identify the stage of the chronic kidney disease. Note that category I12 does not include acute kidney failure, which is an entirely different condition from chronic kidney disease and is not caused by hypertension. So that's why we've got this statement here. We've got acute kidney disease is N17, and it's under and excludes. And here is our statement where if I12.0 or I12.9, we see identified as hypertensive chronic kidney disease with stage 5, and then we go to use either N18.5 or N18.6. If it's stage 1 through 4, then we would go to N18.1 or all the way to N18.4 to use that additional code to identify that stage of chronic kidney disease. So the thing to keep in mind is that chronic kidney disease and hypertension can be listed together, and we automatically go to the hypertensive chronic kidney disease code. If it's stated as hypertension and acute kidney disease, we don't use the hypertensive code. We have to go to the two separate codes. This might be a good place to bring up the new excludes guidelines. Did you notice that that previous slide, this one back here, has the two notations of excludes 1 and excludes 2. So what do we mean by that? That means that excludes 1 means that the code is never used at the same time as the code above the excludes note. Excludes 2 means not included here, slightly different inference. This indicates that the condition excluded is not part of the condition represented by the code, but a patient may have both conditions at the same time. In that case, it's acceptable to use both codes together when documentation indicates that that's appropriate. So keep in mind which excludes notes that you see as your instruction. Back to hypertension and chronic kidney disease now. This illustrates a situation where you would use the code from I12 along with the code from N18 to indicate the stage of the chronic kidney disease. If we've got a patient that's being seen for stage 4 chronic kidney disease and hypertension, then this would be how you would sequence it. Abdominal pain is an example of a change in increased specificity. When documenting abdominal pain, you need to include specifically the location of the pain. Is it generalized or right upper quadrant or right lower quadrant, or where is it? And what is the type of pain? Is it rebound, abdominal rebound pain? Is it abdominal tenderness? just what kind of pain is it. Because, as you can see from this index snapshot, that we have many options for coding abdominal pain. And if you look at them, they all will go to an R character because this appears in the signs and symptoms segment of the code book. Pain should be described as specifically as possible based on the location. So looking at this scenario, we've got a history of the patient coming in with mid-abdominal epigastric pain, and in the physical exam, it's identified as being as having tenderness across the upper abdomen, abdomen being distended and guarding present, bowel sounds diminished in all 4 quadrants. And we also see here, this is what I'm talking about. And then I've also got highlighted patient admits to a history of alcohol dependence, and explains what that means as far as the amounts. I bring this up because that scenario gives us another issue that has to do with alcohol-related disorders. ICD-10 has changed the terminology and the parameters for coding substance abuse disorders. This is a guidance from the ICD-10 guidelines. In this encounter, as the pancreatitis is suspected and the patient's alcohol intake status is stated, the associated alcoholism code can be listed. And that's what I've tried to show here with these little arrows. Maybe they're a little faint, but alcohol abuse is classified under the subcategory of F10.1, alcohol abuse, while alcohol dependence is classified under F10.2, alcohol dependence. An additional code is also required if you know the blood alcohol level. So that's referring back to this scenario here, and I don't see that we have a blood alcohol level, but if we knew, then that would be another code that we would be required to pick up. So the scenario would be coded this way. As you know, in outpatient encounters, when the words such as suspected, possible, probable are used to describe a diagnosis instead of a definitive diagnosis, we can only code to the highest level of specificity. And in this case, it is symptoms of epigastric abdominal pain and tenderness with the jaundice, dehydration, and alcohol dependence at the level that is being documented. Coding otitis media requires increased specificity also as to the type. And the types that we can find identified in the index are things like serous, suppurative, or non-suppurative, mucoid, sanguineous, seromucinous, exudative, transudative, with effusion, or maybe just listed as non-purulent. Other relevant documentation should be specified if the condition is associated with a spontaneous rupture of the tympanic membrane or not, if there's an infectious agent, or if the patient is exposed to environmental tobacco smoke, or is a tobacco user or has a history of tobacco use. As noted by this shot of the category for acute non-suppurative otitis media. Of course, it's also important to document if the condition is acute or subacute or chronic or recurrent, and the laterality, because now we can pick up left, right, or bilateral. So I wasn't able to put the whole pages on here for you, but what I've got is an illustration of non-suppurative otitis media. And what I wanted to make sure that I showed you was the instructional notes here, where it says use an additional code for or to identify. Here we have a documentation of acute otitis media. This is a scenario, and again, the assessment has new onset of acute otitis media in the right ear and suppurative. And under the physical exam, the right ear was seen to be erythematous and with the membrane bulging. So these characteristics and the initial onset, as opposed to whether it's recurrent or not, this is what we need to know in order to code this. In the index under otitis, at the indent for media, you'll find a second indent, and under that you can find separative, which sends you to the next place in the index, and that's what I've got in the smaller box, where we can identify acute. H66.00 in the tabular lets you identify a sixth character that identifies which ear is affected. Now you can see why the documentation specificity is important, because I've got the ICD-9 code listed beside it with its description, and you can see the difference in what it is that we can identify in our codes. So chances are physicians are already putting this in their documentation. It's just, I just want to show you, now we can identify every element that physician documents. Diabetes was another condition that was on that list. Diabetes is classified in categories E08 through E13. Just as in ICD-9, ICD-10 diabetic codes are combination codes that identify the type of diabetes and any complications affecting other body systems. The type of diabetes, type 1, type 2, or is it secondary, is identified at the category level, while the fourth character identifies the presence of any associated complication. The fifth and sixth characters of the subclassification provide further specificity regarding that complication. Use as many codes within a particular category as are necessary to describe all the complications of the disease that you have identified. So here's a look at the tabular sections for secondary diabetes. That's the first, this first picture here, and then here we've got type 1 diabetes. Secondary is due to underlying conditions classified elsewhere, just to make sure that everyone knows what I'm talking about here. And it looks like I've already clicked on to type 1. Here's a shot of a partial listing of type 1 diabetes from the index. This second shot on the right is from the tabular, showing the instruction to use an additional code to identify the site of a foot ulcer or other skin ulcer. I picked that because that's a common diabetic complication, and an example of what you find when coding for a diabetic complication. Here we see shots of type 2 diabetes on the left and other specified, E13, on the right. Notice there are inclusions and exclusions and instructions to use an additional code to identify any insulin use. Insulin use codes are only used with type 2 diabetes or for patients with secondary diabetes to identify long-term insulin use. It's not used for just a temporary period where you're trying to bring down a high glucose, and it is not used with type 1 diabetics because they must be on insulin. So note the instructions here in those two instances. Multiple coding is required for diabetes in several instances, and I've listed some of them here. When the patient has unrelated conditions in addition to diabetes, when the patients have more than one diabetic complication, if you need to provide additional details of the complication, to report long-term insulin use, to report complications due to the malfunction of an insulin pump and any combination of any of these situations. And these are all, as long as you're following the instructions to use an additional or following the guidelines, you shouldn't have any trouble making sure that you've got all the codes that you need to describe your situations. One thing that I wanted to bring to your attention, which in ICD-9 we do have mechanical complications that we can code, but this is a shot of the guidelines from I-10 identifying the fact that now we have a separate code for specifically an insulin pump malfunction complication that I believe is new. And you'll see that comes under the subcategory of T85, mechanical complications of other specified internal and external. And if you drill down, then you will be able to find the insulin pump. Asthma is a chronic lung disease that affects the bronchi and is characterized by inflammation and narrowing of the airways. A common symptom is wheezing due to bronchospasms. Asthma may be extrinsic or intrinsic. Physicians diagnose asthma based on the frequency and the type of symptoms, forced expiratory volume, and peak expiratory flow, which measure lung function. Based on this information, a patient's asthma is rated as intermittent or persistent. An acute exacerbation is a sudden increase in the intensity or type of symptoms. Status asthmaticus is an acute exacerbation that does not respond to the standard medical treatment of bronchodilators and steroids. This is a shot of the index, and I've got two pieces here because I couldn't get all on one long slide. You can see the acute exacerbation of chronic obstructive asthma that sends you to J44.1. So you can find that they're under exacerbation. Here's a shot of the tabular at J44 with the second slide over here showing the choice of J44.0, J44.1, or 0.9 based on the documentations. And you'll see also there's the instruction at the top to use an additional code to identify infection if that's appropriate. I've got an asthma scenario here. We have a patient who has a history of extrinsic asthma who presents with increasing symptoms of cough, wheezing, and shortness of breath. The physician diagnosed this as an acute exacerbation of mild intermittent asthma. For this scenario, we follow the index by finding the main term of asthma, subterm intermittent, and then we go to J45 in the tabular. J45.21 to be exact. Notice again the extensive includes and excludes guidelines at the beginning of the section, along with the use of additional codes instructions to identify all those different things when you get there. The point being here again that now we can code with the documentation terminology that the physicians use to specify intermittent or persistent and not just intrinsic or extrinsic asthma. COPD, chronic obstructive pulmonary disease, is one of the most common lung diseases and is a combination of chronic bronchitis and emphysema as comorbidities. Physicians diagnose chronic bronchitis when patients present with a productive cough on more than 3 months in 2 years, consecutive years. The most common cause is long-term inhalation of irritants. In emphysema, there is an abnormal accumulation of air in the tissue caused by an enlargement or a rupture of the alveolar sacs at the end of the bronchioles. Unlike asthma, the condition is irreversible. In ICD-10, the tabular gives you several instructions as to what is included and excluded in the category of J44 for chronic obstructive pulmonary disease. Notice there's an instruction to code also those environmental factors that may be risk factors for COPD. Our COPD scenario. A patient presents for management of his chronic obstructive pulmonary disease as he is experiencing increased shortness of breath. The assessment is COPD with chronic bronchitis and emphysema. For this scenario, we follow the index to chronic obstructive lung disease with bronchitis, but the code there does not specify the emphysema, so we continue in the index to emphysema. The J44-9 code will include all elements of the disease, even though it's listed as unspecified. This needs to be the code we use. The other choices specify acute exacerbation or with lower respiratory infection. Excuse me. And there's no documentation of either of those. So we picked J44-9. Pardon me. This scenario is for acute exacerbation. We have a 76-year-old female with a history of COPD that now presents with acute bronchitis. The patient has been instructed in the past to stop smoking as it continues to impact her respiratory condition. Under assessment, the physician has noted COPD with acute bronchitis, exacerbation, and chronic bronchitis. His plan is antibiotics for the infection, begin oxygen therapy and counseling in regards to her treatment options for tobacco dependence. Oh, thank you very much. Should have brought a water bottle. Thank you. This scenario documentation highlights the instructional and the sequencing notes in the tabular. So that's what I've got on this page. First, we identify the chronic obstructive pulmonary disease with acute lower respiratory infection by using J44.0. There is a note for identifying the infection, and we do that with J20.9 by locating bronchitis acute in the index. This sends us to J20.9. If we knew the organism, we could specify that with another code or a different code from the J20 section. But since we don't, we stick with the .9. We also follow the coding instructions at the top of J44 to use an additional code to identify the tobacco dependence. That sends us to F17 category, and we can select F17.210 as our choices are in remission or withdrawal, and neither of these fit our documented scenario. So the codes that we end up for this last scenario are J44.0, J20.9, F17.210, and we sequence them in this order. Oh, we're getting close to the end here, and I hope I haven't gone too fast for you. But I have one last thought, and that is to ask if you've thought about dual coding and starting using that in your practice. By dual coding, I mean assigning both ICD-9 and ICD-10 codes to real cases that you're seeing in your practice right now. Although medical practices cannot submit medical claims with ICD-10 codes until October 1, unless they delay it for us again, there are some reasons that it is good to start sooner, or start using them sooner, even if we can't submit them. The advantages being the coders can practice their ICD-10 knowledge. We can look at the clinical documentation and then identify any deficiencies in our documentation. We can also do extensive internal and external testing of our systems before that actual start date happens. And, of course, first you need to know if your practice system can capture both ICD-9 and ICD-10 codes at the same patient encounter. This might be a situation where we actually go old school and write something down on paper. Heaven forbid we go backwards. But this might be a way, again, to work out some of the kinks before that date when you start submitting, and then find out after the fact that there's some problems and your reimbursement isn't happening the way you're hoping for. But I'm guessing that you're already working with your vendors and your payers as to when they will be ready to accept ICD-10 codes and maybe even do some testing before the October 1. So hopefully you are already looking at those possibilities. I guess my next to last thought then is to remind you that HealthPoint offers A&P reviews for coders still, and these are the websites where you can go for more information about that. And everything that I've worked with and I've showed you here comes from these two main items today, the CMS website and also this coding instruction book. It's a very good book if you wanted to get it on your own and walk through ICD-10 training that way. Also, if you are needing a certificate of attendance for either CEs or for some other purpose, here's the email address where you can go, and they will be sending out the certificates of attendance when they get the names of people that need them. And also the PowerPoints that I've showed here will be posted, and this is being recorded so that it can be accessed, and it will be archived and accessed later if you need to, anyone who couldn't get in at this time. So I don't know how we're doing on time. I think I probably took us a little fast. Did we have any questions coming in? Okay. So far, no questions. I think it's all pretty self-explanatory. The best help that I can suggest, again, and maybe I've said this before, is to go to your ICD-10 code book and the guidelines, become familiar with the guidelines, follow all the instructional notes that are either at the section, beginning of the sections, beginning of the subsections, or at the codes. And if you do all of these things, you're probably going to be very successful in identifying the proper codes and just working with the physicians on identifying what documentation might be lacking. And if you can test and do some dual coding at the same time, I think that will be to your benefit also. Anything else at this time?
For about 5 minutes.
Okay. Okay, we'll just stay here for a few minutes. If anyone has any questions or comments, please put them in the chat box, and we'll do what we can to answer them. Yeah. Someone just asked what were the 3 main changes, and those are definition changes, terminology differences, and increased specificity. So that has to do with how certain conditions have been defined differently now in ICD-10, and maybe the use of some of the terminology is a little bit different. And then, of course, the increase in specificity. Thank you for asking. Okay, any other questions before we go ahead and sign off? I hope this has been helpful for you. Okay, there doesn't seem to be anything else coming in. So you all have a good day. And hold on just a second. Maybe it's, please list the website again. The one for HealthPoint, okay. Let me, go back up here. There we go. I don't know how soon these PowerPoints will be posted, but within a day or so, at least by next week. But I'll leave this here for a minute if you want to just jot that down. And don't forget the email address if you need certificates of attendance. Okay. Well, if there's nothing else, then I guess we'll go ahead and sign off, and you can all go to lunch if you haven't been already enjoying lunch while we've been talking. All right. Have a good day.